the biggest thing that we watch for, and if we're really worried about someone being truly profoundly hypothyroid, is assessing growth. So the growth chart is really important in pediatric care in general. So for patients who have profound primary hypothyroidism, they would typically present with linear growth failure. So they're not growing height-wise the way that they should.
A tired teen who struggles to get out of bed. A child whose growth is not keeping up with expectations. These are problems we see commonly, each with a long differential diagnosis. Thyroid disorders are often on the differential for many common symptoms we see, and yet thyroid disease rarely walks into the office announcing itself. Instead, thyroid disorders can hide in plain sight, disguised as other diagnoses such as anxiety, depression, ADHD, delayed puberty, constipation, or just teenage hormones. In this episode, we're diving into the physiology, the pitfalls, and the practical decisions behind pediatric thyroid care. Because when we understand the thyroid, we protect long-term health. This is Charting Pediatrics. Joining us for this episode is Dr. Maggie Chan, an endocrinologist in pediatrics here at Children's Hospital Colorado, as well as an associate professor of pediatrics at the University of Colorado School of Medicine and a fellow alumnus of Vanderbilt University. Maggie, nice to see you. Welcome to the podcast.
Thank you for having me.
You're an outstanding clinician, and thyroid disease, I know, is a lot of what you see in clinic. So tell us about some of the most common disorders of the thyroid that you see in children and adolescents in your practice.
Yeah, probably the most common thing that we see is acquired primary hypothyroidism. So this often presents in childhood and adolescence. To a lesser degree, we also see babies born with congenital hypothyroidism. For us, it's a little bit more common, but probably not for your general practitioner out in the community.
What about hyperthyroidism? Is that something you run into much in kids, or is that largely an adult problem?
No, we definitely see that in pediatrics as well. Again, for us, very bread and butter. I would say out there in the clinical community, folks probably don't see as much in their patients having hyperthyroidism, but we definitely see that on a regular basis.
Great. And what do you see in terms of patients that are coming to see you and referring pediatricians? What are we sometimes missing or overdiagnosing when it comes to thyroid disorders?
I think what we tend to see in clinical practice, occasionally there's maybe a little bit more overscreening that sometimes can happen as far as checking for thyroid disorders. But on that note, I'd rather folks check more and, over test to some degree than miss a patient or a child who has a true thyroid disorder due to not checking. So it's hard to, gauge whether something is really happening too much or more than necessary.
And I feel like we all send thyroid testing for so many things because there's so many different symptoms that can be associated with hypothyroidism in particular. So let's talk about that. In the primary acquired hypothyroidism that you described. What is it and what is happening pathophysiologically? And then let's talk about different symptom presentations based on age.
Yes. So for routine primary acquired hypothyroidism, what that is basically the thyroid gland, which is located in the front of the neck, is not functioning the way that it should. So for those patients, if the pituitary gland, which is a little gland kind of in the middle of your head, I guess, behind your eyes, is functioning properly, it will send out a signal to tell the thyroid to produce the right amount of thyroid hormone. So for those patients, if we're worried about primary hypothyroidism, the best screening test is a TSH. However, the concern there is if there's any reason to worry about something called central hypothyroidism, which is where the pituitary gland is not properly producing that signal, then if you just check a TSH, you might miss that diagnosis. So for those patients, it's really important to check a TSH as well as a T4.
Got you. And what's happening in the thyroid gland that makes it not function normally? Is it Does it just burn out, or is it somehow being attacked and destroyed? What's happening?
Correct. So again, for primary acquired hypothyroidism, the most common cause is autoimmune. So in those patients, the body has developed what we call antibodies against the thyroid cells, and they're essentially getting destroyed over time. So that inflammation will destroy the thyroid cells, and then they will not function the way that they should.
And how important is family history in terms of understanding what's happening in a child?
Definitely, we tend to see more autoimmune hypothyroidism in patients who have a family history of autoimmunity. Now, there are lots of autoimmune diseases out there, ranging anywhere from, again, hypothyroidism to things like inflammatory bowel disease, multiple sclerosis, many other different things like type 1 diabetes, for example. So definitely family history plays a role in determining who to screen. Although I wouldn't screen primarily just solely based on family history, though.
Yeah, important that we're looking for symptoms too. And
Correct.
Speaking of symptoms, you mentioned that this can even present in infants, but let's talk about common symptom presentations, let's say in toddlers, school-age kids, and then teenagers.
Yeah, I think the biggest thing that we watch for, and if we're really worried about someone being truly profoundly hypothyroid, is assessing growth. So the growth chart is really important in pediatric care in general. So for patients who have profound primary hypothyroidism, they would typically present with linear growth failure. So they're not growing height-wise the way that they should. The symptoms that you read about in the textbooks are often pretty vague. So you'll hear things like fatigue, constipation, changes in hair or skin. But again, this is typically when hypothyroidism has been going on for a long time. And as we know, there are many things out there that can cause patients to feel tired or constipated or have dry skin, especially, here we're in Colorado, it's definitely very dry. So it's hard sometimes to tease out whether it could be a symptom of hypothyroidism or not.
So for kids that are still growing in terms of their height, that's the primary thing to look for. What about in teenagers? What are the things that you're worried about?
Yeah, so teenagers are a tricky population because there are so many symptoms that can be due to other things. As you mentioned earlier, mood changes, just sleep hygiene, many different things that can contribute to these types of symptoms in teens. However, in the interest of not missing something that's very treatable, it's very reasonable to check for thyroid dysfunction when evaluating kids for these types of things.
So what I'm hearing is if you're a pediatrician and you're seeing a kid for a well-child visit and they're flatlining in terms of their height velocity, let's say, that hypothyroidism is one of the first things we should think about.
Correct.
Yeah. And as a gastroenterologist, I would also say celiac disease is a common thing that can present in a similar
And we also
fashion.
screen for that when we're evaluating patients for growth. Absolutely.
Smart. And so that's really super important to keep in mind. Let's talk about laboratory testing, because you mentioned the TSH, you mentioned the T4, but I know you guys get tons of phone calls about thyroid tests. When should we be worried based on deviation from the normal range for those types of tests? And how does that influence either referral to you or watchful waiting or rechecking labs? How do you think about that?
Great question. So I would say that if a TSH is checked and it's mildly elevated, and we consider mild elevations to be approximately between 5 to 10, then the first thing to do would be to repeat that at some interval period. So a reasonable time frame might be, 2 or 3 months to check and see, because oftentimes we'll see mild elevations that then return to normal. So that would be one thing to consider. Likewise, if patients have been recently ill, there's a lot of things going around, different times of the season. If children are sick at the time of their blood draw, then that may affect the levels, and it's prudent to check again at some interval time period before determining if this is a real elevation or not.
Do you typically recommend, you mentioned central hypothyroidism due to pituitary dysfunction. If you're not worried about that, should we just be starting with the TSH and not checking the thyroid hormone?
Yeah, that's a really good question. And I actually think for initial screening, it's very reasonable to get a TSH and a T4. And the reason for that is a lot of times, and as I mentioned earlier, we're evaluating patients for growth. So if patients are not growing well and we're worried about other things that might cause growth failure, like growth hormone deficiency, for example, since growth hormone deficiency is related to the pituitary gland and a whole separate topic, it would be important to check and screen for central hypothyroidism, which is also related to the pituitary gland. So I think for kids, it's very reasonable to start with a TSH and a free T4 if you're evaluating a patient for growth. If it's screening just primary hypothyroidism because there's a family history or something like that, then I think a TSH is reasonable.
Oh, that's interesting. So let's say you have that growth failure, you check both the TSH and T4, and let's say there is a central problem. What is the lab findings that you would expect in that situation?
Yeah, so if we are worried about there being some sort of process going on in the brain, then the concern there is that you might get a low T4 without an appropriately elevated TSH. So that would be a red flag for getting endocrinology involved sooner rather than later.
Yeah, because that could also mean that there's growth hormone deficiency and other problems, right? Which can be more complicated diagnoses. Oh, this is super helpful. So, okay, mild elevation, we recheck that in 2 to 3 months. What's the threshold at which, hey, I should call you, and with a consideration of maybe starting treatment and initiating a referral? What's that threshold where we should be calling?
That is a good question too. I think for us, if the TSH is above 10, then we're definitely thinking about, this could be, true hypothyroidism, and do we need to initiate treatment?
Okay.
That said, I have seen TSH values that are upwards of 10, again, in certain situations like during illness. So I don't want to say every patient who has a TSH greater than 10 is going to warrant treatment, but certainly that would be when it would be reasonable to start thinking about whether treatment is needed. If it's very, very high, many fold, times upper limit of the reference range, then that would be more important to get us involved sooner rather than later.
Okay. I like that. So greater than 10, get your local pediatric endocrinologist involved in the situation, and they can help guide the urgency of the visit, et cetera.
Yes,
okay.
Correct.
That's great. Let's flip this and talk about hyperthyroidism. So what's the role of the pediatrician in recognizing, say, Hashimoto's, thyroiditis, or Graves' disease? What should they be looking for in their clinics?
Yeah, so Hashimoto's thyroiditis is usually presenting with hypothyroidism, actually, and not hyperthyroidism, although this is very nuanced, but there is a subset of patients who have Hashimoto's thyroiditis who have an initial hyperthyroid phase. Okay. So that's a little tricky, and we leave that to the endocrinologist to sort out.
Yeah.
For Graves', which is autoimmune hyperthyroidism, this is considered a more urgent reason to see endocrinology. So certainly if there's concerns about this, that would warrant an urgent referral. And I can talk about what the labs would look like.
Yeah, let's talk also about the most common symptoms that you would see with a diagnosis of Graves' disease in the pediatric population.
Yes. So the most common symptoms would be palpitations. So feeling like heart is racing or beating really fast. Patients might say they feel jittery or anxious for no explained or obvious reason, have difficulty sleeping, be very kind of hyperactive and fidgety. Again, you can see that for other reasons.
I know.
Too,
I mean, let's talk about that because that's a big challenge. We've been talking a lot on our podcast about the mental health struggles that our kids are facing. Our pediatricians tell us that can represent sometimes a third or a half of the patients they see in a day. Yeah. So how do you discriminate between the very commonly anxious school-aged kid and adolescent and someone who has Graves' disease?
Yeah, that's a great question. I think for someone who has Graves' disease, they are going to feel like this kind of all the time, persistently. And that sensation of having palpitations will be present all the time also. Again, tough to say for sure, though, if it could be due to a thyroid issue or not without checking.
So asking what they're anxious about, right? So that sense of your heart racing or skipping, I mean, that's a very specific description of a symptom, right?
Right. And is it happening around a stressful thing? So that could help tease it out too. Am I worried about a test today or something that's happening, which might be more of an anxiety thing as opposed to I'm not doing anything and I'm feeling really worried and I don't understand why. That might make me lean more towards screening for an underlying disorder.
So let's talk about lab evaluation when you're concerned for hyperthyroidism in the setting of Graves. What should we be checking for? What should we be expecting in terms of results?
Yeah, so the screening is similar. Again, we would check a TSH, which we would expect to be low, as well as a T4, which we would expect to be elevated for someone with hyperthyroidism.
And then let's say we get those labs back, urgency of referral to see you. How does that stack up against, say, hypothyroidism? Like, how soon should we be advocating for an appointment?
Yeah, so for a patient who is truly hyperthyroid, and by that I mean the TSH is, let's say, undetectable, so it's less than the lower limit of the normal range, and the T4 is frankly elevated, we will get those patients seen within a week usually. So it's pretty urgent.
So you want to see those patients quickly?
Correct.
And if their disease progresses without treatment, what else could happen?
So they can get very ill. There's a complication called thyroid storm. Thankfully, we don't see that very often, but when it happens, it can be potentially life-threatening in extreme situations. So we do consider this to be more urgent for sure.
So refresh my memory, because it's been a while since I took my general pediatrics boards. Obviously, for hypothyroidism, you're going to treat by thyroid hormone replacement.
Correct.
For Graves' disease, what's the current state of treatment for that problem?
Yes. So typically for Graves' disease, we will start, there's 3 different treatments. Medication, so anti-thyroid medication that blocks the thyroid from producing too much thyroid hormone. Typically, we start with that. The other 2 options are considered definitive, meaning once you do this treatment, you can't reverse it. And so that would be thyroid surgery to take out your thyroid gland, or something called radioactive iodine, which basically chemically destroys or ablates the thyroid gland. But again, those latter 2 are permanent. You can't undo it once it's done. So most
Meaning
of the time,
you then make someone hypothyroid, right, and commit
Correct.
them to thyroid hormone.
Yes. So typically we don't start with those. We start with the medication and see how patients respond.
So we've talked about lab interpretation. So what are some of the most common mistakes or misinterpretations that you see by referring providers in terms of common thyroid labs?
So one thing that I think is important to point out is that patients who are on estrogen in some form or fashion, so the most common thing would be like a birth control pill, those patients will often have a elevated total T4 without an abnormal TSH. And it's just because the way the assay works is that there's thyroxine binding globulin that basically will bind the thyroid hormone and cause an elevation when it's measured. So when we see that, we don't worry if a patient is on estrogen of some form, and that's the explanation. So no need to get concerned about that.
Okay. Any other misinterpretations that you commonly see?
Yeah. So these days, with more supplements out there in the world, in the community, if supplements contain biotin, that can also interfere with the assay. That picture tends to look more like hyperthyroidism. So the TSH is low and the T4 is elevated. So the recommendation is actually to hold supplements that contain biotin for about 3 days before getting thyroid labs. So that's another common thing that could potentially interfere with thyroid levels.
Yeah. So got to ask about all the supplements that patients are taking.
Correct.
And you talked about how illness can sometimes impact thyroid labs. Are there other just normal conditions or patient conditions that could impact the normal range for labs, or where they fall out?
Yes, another great question. So mental health things like depression, anorexia, that can sometimes affect thyroid levels too. So certainly we have to interpret that in the context of what's going on with the patient. This probably doesn't come up as much for primary care providers in the community, but the time of day actually that thyroid levels are drawn can impact the TSH in particular. There's a kind of diurnal rhythm. So
interesting, kind of like growth hormone, I guess.
Yes,
right?
yeah.
Okay.
Now for patients who are in the hospital, let's say in the middle of the night because they came in to have something done, it's not uncommon for the TSH to be a little bit elevated when checked in the middle of the night. So it could just come right back down to normal if it's repeated later in the day.
That's super interesting. Let's talk about another thyroid issue that may come up in primary care, which is just feeling an abnormality in the thyroid exam. Like if you feel a nodule, for instance, What's the right next move for a pediatrician?
Good question. If there's an actual abnormality that's palpated on exam, then my recommendation would be to start with a thyroid ultrasound.
Okay.
I do want to take a moment and say that for your routine patient that you're seeing who's got a family history of thyroid dysfunction or Hashimoto's or hypothyroidism, we don't recommend doing just baseline screening ultrasounds for all patients because the rate of finding some incidental finding is going to be high, and then we're going to have to follow that.
Follow the goose chase, the wild
Yes,
goose chase on that.
For sure, though, if you feel something abnormal, either nodule, like you mentioned, a significant asymmetry in the size of the gland, one side being a lot bigger than the other, that would be a reasonable indication to get a thyroid ultrasound as the first step.
So ultrasound, not necessarily lab tests for that situation.
Well, I would do an ultrasound for the imaging, and I would get thyroid labs as well.
How common is thyroid malignancy in kids? Is that something that we should be worried about?
It's rare.
Okay.
But we do see it. In fact, it's one of my personal areas of expertise.
So let's talk just for a second about that, since that's something you think about a lot. What are the types of thyroid malignancy that can be seen in kids? And do they present usually as a mass or with other symptoms?
Another great question. So the most common type of thyroid cancer is papillary thyroid cancer. That's over 90% of what we see in the pediatric population. Most of the time, unfortunately, for children, it presents quite locally aggressive already and will often have already metastasized to the lymph nodes. So oftentimes children are presenting because someone notices actually lymphadenopathy or enlarged lymph nodes, and it turns out that it's coming from something in the thyroid gland.
Wow. So usually present with a physical manifestation versus some hormone overproduction.
Correct. Yes. In fact, I would say that the majority of patients still maintain normal thyroid function with thyroid cancer. It's not that they're presenting because the thyroid isn't working the way that it should. It's usually someone feels something or there's an incidental thyroid nodule picked up on some other imaging that's obtained for some other reason.
This has been awesome learning, Maggie, for me. And I know for all of our listeners, if there were 3 things that you wanted all of our pediatricians to know about the thyroid, the most practical takeaways, what would you say?
I would say, and we didn't actually touch on this during the episode.
Well, let's get to it.
But I would say that it's not uncommon to see a mildly elevated TSH in patients who are overweight or obese. And we all know that there's, the obesity epidemic, these days, and we see lots of overweight and obese children. It's very common to see a mild elevation in TSH for those patients, and it's not thought to be clinically significant for most of them, nor is it the cause of their weight gain. So that would be one thing
That's
I would
huge.
definitely highlight.
Important.
Second thing would be to screen for thyroid dysfunction for children who are not growing appropriately. So linear growth failure should definitely raise one's eyebrows for potential thyroid dysfunction.
Can I ask one follow-up question about that? When those kids have growth failure at the same time, what's happening to their weight typically at the time they're experiencing growth failure?
Yes, good question. So usually they're gaining weight appropriately. Okay. So it's appropriate weight gain in the context of linear growth failure, as opposed to patients who are, just eating more calories than they need or whatever. Those patients typically will have increased weight gain, but also their height trajectory will be preserved.
So their BMI is increasing because their weight is appropriate, but their height is flatlining. Typically?
This is flatlining for hypothyroidism.
For hypothyroidism,
correct.
Right? Okay.
Yes.
Great. All right. One last takeaway, because these 2 have been great. One last one.
One last takeaway.
Maybe around labs, like what should we do for the mildly elevated? Like how long should we wait before repeating it?
Okay. Yes. So if you see a patient who has a mild elevation in TSH, so between, again, I'm going to say 5 to 10, then the first thing I would do is just repeat them in, let's say, 2 to 3 months and see if that elevation persists, as opposed to right away.
And reassure the parents, the nervous parents.
Yes, reassure them that this is unlikely to be the cause of whatever symptom is going on. Doesn't mean we're going to not address it or not follow it, but that it's likely not causing what's going on right now. But we're going to pay attention to it and we're going to monitor and repeat.
I think that's really important because you don't want the family to assume that one lab test that's slightly out of the range explains the symptom when there's probably something else happening. So it's really important to disentangle those things, right?
Right. And we want patients and families to feel heard too.
Yeah.
So we don't want them to feel like we're dismissing their concerns. It's not that at all, for sure.
So thank you, Dr. Maggie Chan, pediatric endocrinologist extraordinary. Thank you for joining us today.
Thanks for having me. Appreciate it.